I would like to introduce Dr. Shinnosuke KOMIYA, a fertility specialist who has worked for years as assistant director at one of the largest IVF centers in Japan. Today, he will shed some light on the impact of ERA, EMA, and ALICE on euploid embryo transfer. Okay, Dr. KOMIYA, please.
Thank you for your kind introduction. And my name is Shinnosuke KOMIYA. And today my topic is impact of ELA MRS test on euploid embryo transfer. So let's begin. Okay. There is no COI regarding this content of this presentation. First of all, let me explain the current status of PGT-A in Japan. In Japan, Pcta is not a regular fertility treatment option, but being introduced on a limited basis as a clinical study by the JSOG, Japan Society of Gynecology. And our group hospitals are certified as research supporting facilities. The following chart are the requirement for participation in Pcta clinical studies. Pcta for chromosomal structure abnormalities is in a separate category as PGT-SR. So today I will talk about Pcta. Its repeated ART unsuccessful and repeated miscarriages are indication for Pcta. And SOG preclinical study suggested that Pcta could be useful as the appropriate embryo selection. There are issues that need to be resolved for implementation. There are three main problems. One is for financial problems, and two is the problems of having acquired blastocyst. It's very difficult to growing up a blastocyst, or very low ovarian reserve patient is very difficult to go to select the Pcta. And the third one is the risk of embryo damage. Of the Pcta performed at our group hospital since April 2020, 238 cases were tested by Igenomix Japan. When we looked at the number of blastocysts of the grade that can be used for Pcta, nearly 70% case less than 4 blastocysts for Pcta. And in 68.4% of cases, at least one Euploidy embryo was acquired. In this study, mosaic embryos were classified as aneuploidy in order to simplify the discussion. In 19.2% of the cases, the number of Euploidy was less than 4. The 238 patients who underwent Pcta were divided into two groups. Those who achieved Euploidy is categorized as Euploidy group, and the patient who can get only aneuploidy or mosaic embryos are classified as only aneuploidy groups. And the patient background were compared with Mann-Whitney U-test. The age of females and males was significantly lower in the Euploidy group, and there was no significant difference in the number of oocyte retrieval cycles for the purpose of Pcta, but the number of blastocysts available for Pcta was significantly higher in the Euploidy group. We traced embryo transfer outcomes after Pcta. The Euploidy group shows the embryo transfer result with only Euploidy. And in some cases, multiple cycles of embryo transfer was necessary. And the only aneuploidy groups describes the result of embryo transfer using mosaic embryos or day 3 embryos or blastocyst without Pcta. And they reflect the result of up to 3 embryo transfer cycles after the oocyte retrieval cycle for Pcta. Significantly improved fertility outcomes were shown in the Euploidy group. On the other hand, 14.6% of the only aneuploidy group was also found to be ongoing. From this, it can be said that in cases where it is difficult to develop blastocysts or where the number of eggs retrieved is low, it may be recommended to choose regular IVF or ICSI without aiming for Pcta. And we would like to examine the mosaic embryo separately on another occasion. We then examined whether the number of Euploidy acquired will affect the ongoing rate. The Fisher's exact test showed there is no significant differences between number of Euploidies. Considering that 90.2% of Euploidy recipients have less than 4 Euploidy, and that there are some cases where multiple cycles of oocyte retrieval are required to obtain Euploidy, it may be acceptable to proceed an embryo transfer even one Euploidy embryo is obtained. So here's the main topic. Does the ERA MRS test contribute to improve Euploid outcomes? We thought it will be clinically significant to examine the efficacy of each test under the condition that embryo selection is properly conducted by Pcta. The purpose of conducting an ERA test is to identify WOI, window of implantation. I showed the patient A, patient B, patient C are shown in the figure. In general, blastocyst transfer is often done at the P+5 with the start of uteral replacement at P+0. The WOI is said to vary slightly from person to person. In this case, patient A is in the receptive phase on the day of P+5, while patient B is in the pre-receptive phase and patient C is in the post-receptive phase. The ERA test analyzes the genes expressed in the endometrial tissue. Basic research have identified a total of 248 genes that are expressed at different phases of WOI, and by evaluating the expression of each gene, it is possible to determine which phase the endometrium of the patient is in. So this figure, patient A is in the purple area, it means receptive. And patient B's genes expression is in the blue area, and patient C is in the pink area. So we can detect what condition is in. In the original paper reported the ELA testing can be done in natural cycles, but in our clinic, ELA test is limited to HRT cycles in order to accurately determine when to start progestin replacement. And endometrial biopsy will be performed at the day of P+5, and depending on the result obtained, embryo transfer will be performed at the personalized timing in the next embryo transfer. This is a summary of the result of ELA test performed in our group to date. including cases prior to the start of the Pcta clinical study. The highest number of cases were found to be receptive at 126 hours after the start of progestin supplementation. Overall, there are 3 peaks indicated by bluebirds: 100 hours, 125 hours, and 550 hours. And the results of the error test are obtained the time after of progestin replacement, but a range of about 6 hours are acceptable. This suggests that 196 cases shown in the red and orange bar are those that directly benefited from the error test. However, since all subsequent embryo transfer will be done in personalized timing, the benefit to a limited number of cases will be difficult to evaluate statistically. First, we compare the patient background of error and non-error groups for Euploidy group. There was no significant difference in age, number of oocyte retrieval cycles, number of blastocysts submitted to Pcta, and the number of Euploidy acquired. Then we compare the fertility outcomes between the error and the non-error groups. As originally predicted, no significant differences was found, and clinical studies with appropriate design are needed. It will be statistically more accurate to divide the patients who were found not be receptive by error test into 2 groups: personalized ET group and ET with P+5 group. But this will be difficult to achieve because of S-score ratios. As a supplement to this point, here are the results of RCT presented at the ASRM annual meeting 2014. And this data summarizes the result of an RCT of embryo transfer after ELA test presented by Dr. Luis Alonso and her group in 2014. Based on the actual chart, the wording has been changed, but the numbers remain the same. This study suggested that the transfer on the day of non-receptive P+5 had been inappropriate. When conducting Pcta embryo transfer, it may be necessary to coordinate with error test to ensure that the embryo transfer is performed at the appropriate time. In addition, in recent years, there has been reported that WOI is skewed in cases of endometrial dysplasias, so it is necessary to consider which test to prioritize. Next, let's move on to the discussion on microbiome. The human life is symbiosis with bacteria and have them in every part of our body: the digestive tract, oral cavity, and skins, and all places, and the reproductive organs are no exception. Basically, the bacterial flora consists of the great variety of bacteria, but it is known that the female reproductive organs such as the vagina or the uterus have significantly less diversity. Lactic acid and hydrogen peroxide produced by lactobacillus maintain an acidic environment and a robust environment where the growth of other bacteria is suppressed. In the past, the endometrial cavity was thought to be sterile, but in recent years, it has been pointed out that the endometrial cavity has its own bacterial flora, which may be closely related to the implantation environment. The MRS test is a method to reveal this intrauterine cavity's microbiota using 16S ribosomal RNA sequencing technology. And this is the total number of cases of MR tests performed at our group facilities to date. Approximately 10% of the cases performed were inappropriate specimens for which result could not be obtained because of extremely low DNA amount. And as with the error test, we compared the patient background of the EMA and non-EMA groups. The number of Brussels cysts submitted to Pcta was significantly higher in the EMA group, and there was no significant difference in the parameters. And we performed the Pca analysis. Principal component analysis was performed to determine the characteristics of the bacterial flora. In general of microbiome papers, the principal coordinate analysis PCOA was performed in regular, but today I performed choice the Pca. It means there is no differences to express the whole balance of the flora, so I chose this. This time we use the PRCOM function of the statistical software R and the ggplot2 packages to illustrate the figure. It is important to note that all cases are repeated IRT failure or repeated miscarriages because we are now focused on the PGT-A cases. First, we considered the endpoint as implantation. The pink dot is the no implantation cases, and the blue dots indicates implantation cases. And there is no significant differences on the Parma-Nova analysis. We then added analysis using the random forest algorithm to evaluate the importance of each bacterium to implantation. The random forest package of the statistical software R was used to analyze and illustrate the result. It should be noted that in this study, only the genus level was evaluated. Some anaerobes and the other bacteria have been shown to have a positive effect on implantation, but clinically, I think they should be considered as bacteria that have also been identified in the presence of lactobacillus. Next, the endpoint was changed to ongoing, and the same analysis was performed. The Pca was exactly the same. And interestingly, when the endpoint was set to go ongoing, the importance of some bacteria changed. However, as in the previous slide, this is only looking the bacteria identified the presence of lactobacillus and is therefore of little clinical significance. While lactobacillus is of course important, the importance of bifidobacterium was noticeable in this study. Compared to lactobacillus, bifidobacterium have bifidobacterium has shown to have inadequate acidity compared to lactobacillus, may be beneficial for implantation. Further studies are needed, I think. The fertility outcomes of EMA group and non-EMA group were compared. There were significant differences between the two groups, but there was a reason, I think. The result was due to the fact that the EMA group had a mixture of lactobacillus dominant and post-treatment dysbiosis cases. Dysbiosis cases were treated with antibiotics and lactobacillus preparations, and retesting confirmed that they had changed to lactobacillus dominant endometrial flora. However, additional analysis was conducted to see if the history of dysbiosis has an impact on fertility outcomes. This is the result of additional considerations. The group that showed more than 50% of lactobacillus occupancy was defined as the lactobacillus dominant group. A comparison of fertility outcomes between the dysbiosis group and the lactobacillus dominant group showed a significant improvement of Euploid ET outcomes. The following is a summary of suggestions from the study of EMA test. It is important to evaluate the endometrial environment with EMA test before performing Euploid ET because Euploid ET with endometrial lactobacillus showed increasing of the progestin prognosis of infertility treatment. On the other hand, although the pregnancy rate of dysbiosis cases was higher than that of the only aneuploid group, it was significantly lower than that of the lactobacillus. The results are similar to previous report that the presence of lactobacillus is associated with higher pregnancy rate, but the future challenge is to establish treatment for dysbiosis cases. Even if the retest confirms that the dysbiosis cases are in the lactobacillus dominant status, it is possible that they have reverted to dysbiosis afterwards. In addition to detailed studies, it will be necessary in the future to clarify how to control the endometrial flora with minimal impact on the systemic flora. The difference in patient background. It is important to note that the number of breast cysts submitted to Pcta was significantly higher for those who performed the EMA test. Since this study was not an RCT, it is possible that the cases that were able to acquire more embryos may have requested EMA test before the result of a Pcta were available or may have been recommended by their doctors. At another time, we will add a study with correction for patient background. And this is the take-home messages. Pcta is one of the effective adjuvant treatment to achieve pregnancy in LIF cases. Even in that Euploidy, 14% were ongoing using mosaic or non-Pcta embryos. And ERA test may improve fertility outcomes with or without Pcta. And if the EMA test can confirm the presence of lactobacillus, even better fertility outcomes can be expected. And if even one Euploidy has been obtained, ET is probably a good idea, and it may be necessary to stick with PGT-A for cases who is difficult to achieve blastocyst. And the future tasks, increasing the number of cases to study or RCT or better design study is needed. And of course, prospective study and non-PGT-A patient forecast study is needed. And we also aim to establish appropriate treatment strategy for patients with endometrial dysbiosis. And this treatment means not only turn the dysbiosis cases into lactobacillus dominant cases, but also improve the prognosis of a pregnancy. And special thanks to Mr. Andy and Mrs. Ishii and all the staff of Igenomix Japan and Dr. Morimoto, Dr. Okada, and all the staff of HORAC Ground Front Osaka Clinic, Kansai Medical University. Thank you.
Okay, thank you very much, Dr. Komiya. We have a few questions here online. Let me start with the first question that a doctor from Taiwan asked, what is the definition of Euploidy here in your study? What is the definition, for example? Like I think the question is to ask you whether if you see any mosaicism and what is the percentage of the mosaicism that make you define the embryo is Euploid.
I'm so sorry, but I don't know. I don't have any information about this because the embryologist have judges and they make papers for the doctors. So I'm so sorry not answer this question.
Okay, thank you. I think from our on behalf of Igenomix, I think we can suggest that our definition of mosaic system starts from 30%. So anything below 30%, we define that as Euploid. So I believe this is probably the answer that the doctor would like to know. Okay, so let me ask you some other questions that the audience proposed. The first question is that in your take-home message, in your slides, you have a take-home message, and you also showed that 14.6% of the non-euploid embryos has the ongoing pregnancy. Did those patients take any HORAC or Pca Analysis test as well, or it's just they only took the Pcta test?
Okay, the non-Pcta patient choice any other test. They also perform the ELA or test or Pca Analysis test, but in this slide we cannot enough time to statistical analysis. So I'm so sorry, but I cannot show the detail of the cases.
Thank you. And also another question is, in your opinion, what could be the mechanism or what is the function of lactobacillus that in the endometrium?
Maybe in vaginal area, the lactobacillus makes the lactic acid or the hydrogen peroxide, and they keep the acidic conditions. And in endometrial phase, I don't know well, but maybe they controlled other bacteria, and or there are some probability to they make some kind of cytokines or the immune systems, but maybe basic research have needed.
Okay, thank you. And then also, I think we have a question from Vietnam that the question is, endometrial lactobacillus can improve fertility outcomes. How can we increase lactobacillus in the endometrium?
Yeah, our facilities use the antibiotic oral intake drugs and lactobacillus vaginal drugs, and also oral pill, but it shows not enough effect to make the pregnant rate to be better. Yes, so we need some different method to control the flora about vagina or endometrium.
Okay, thank you very much, Dr. Komiya. That I think we have run out of the time. Thank you very much for your comprehensive and presentation, and also answering all the questions that the audience asked. Thank you very much. Thank you again, Dr. Komiya. Thank you. Okay.
Thank you.